perspective when I have put Chaturmukha Samarambham, Bhagavadacharya Madhyamam, Basmadacharya Paryantam, Vande Guru Parampara, Ragadi Rogan, Sattanushaktan, Asheshakaya Prasadan Ashesha, Autsukya Mohanattan Jagana, Apurva Vaidya Namostu Tasmai. So remembering once again all gurus, as I already mentioned yesterday, the thing that I would like to share with you all is the little experiences that I have in that area. So today, the topic of our discussion is application of Jwara Chikitsa in various diseases, a discussion. So the main perspective when I have put like a discussion, it indicates, the various aspects that we can take from the sutras that we have discussed yesterday, like where to apply Vamana, where to apply Virechana, where to apply Svedana, etc., and how they can be applied in the clinical scenario in various sampraptis. So I think broadly the contents of my presentation would be application of Jwara Chikitsa Sutra and its experiences with special reference to rheumatoid arthritis, Sjogren's syndrome, skin diseases, neurological cases. How those sutras were applied in these cases, and then the responses were observed. I think these are the things that I would like to share with you out of our clinical experiences. So the sensibility of taking these diseases, as I mentioned, these are one of the major group of diseases that have the possibility of application of Jwara Chikitsa in various avasthas. So we will directly move on to the area of discussion. It is like rheumatoid arthritis we will discuss first, and then Sjogren's syndrome, which is of course not very common, but a condition where the many a times the cases approach us because they need really a solution, and the spectrum of skin diseases that can come to us, and of course neurological cases. So I'll be discussing the case experiences in that perspective and application, and I'm sure we will have a good discussion at the end too. Okay, so directly on to the topic. So as far as we are concerned, rheumatoid arthritis, we generally keep it in the spectrum of Vataraktam. Okay, I do know that when it comes to the northern part of India, it is Amavatam that is directly related, and we generally related it with Vataraktam. Now, I don't find any like contradictions in the background because Brihatrais does not much speak about Amavatam, but they have spoken about Samavastha of Vataraktam. So I think when the clinical presentation has been put up with a different entity in the background, with more of such clinical presentation, Madhav Nidanam has added Amavatam as a separate entity, wherein Kabha is more dominantly seen in the Samprapti. But of course, when it comes to Vataraktam, we do understand. So any RA cases, if we could find Pitta Rakta Dushti in the background of Nidanam and Samprapti, we definitely keep it as Vataraktam. And most rheumatoid arthritis cases do have that background. So we keep it under Vataraktam. Okay. And of course, when it is more of Amavastha in the background, Alasya, Mavipako, Aruchi, etc., Shunata, Angana, Jwara, etc., being a part of the Samprapti and Lakshana, then of course we diagnose it as Amavatam. Okay, that is the thing. So, in the ground level in clinics, when we say, when the patient comes to us, generally, the variability we definitely need to consider. Like, Kabaja, Paitiga, Vadiga, Vata Pitta, Pitta Kapha, Kava Pitta, Pitta Kapha, Kava Vada, Vada Kapha. The dosha dominance and the variability of the clinical presentation helps us to decide whether should we go for Vamana or Virechana or Vasti or what. So I'll be discussing Kriya Kramas only over here. No Shamana Aushadhis, because our topic of area of discussion is Kriya Krama itself. So that is the so primarily as a clinician, the thing that we need to understand is about the variability. So I think when a patient comes to us primarily with all this Madhyama Roga Marga presentation like joint pain, etc., first thing, as we all know, we have to categorize it into Uttana Vadrakta or Gambhira Vadrakta. So the sole one point clinical point for us to realize clinically, I would definitely say it as the guidelines. Kandu Daha Rug Ayama Toda Spurana Kunjanehi Anvita Shava Rektatvak Bahye Tamra Tadrishyate. When the patient present with Kandu, patient has got some skin lesions. Definitely it is in the Bahya Uttana Vadrakta stage itself. So once we intervene, definitely we have much possibility of almost retrieving the entire disease process. What is my experience is, like, if we get a case with the onset of the clinical presentation without undergoing any allopathic medicines, they are coming to us with a history of at least 6 months or within 1 year, we'll be able to revert the pathogenesis, no doubt. Provided the patient is young and is ready to follow the Patyahara and Vihara. Definitely we can do that. There is no doubt about it. Now, Vayuhu Sandhyasti Majjasu Chindaniva Charanti Antar Vakri Kurvascha. When we have Sandhyasti Majjasu Vakri Kurvascha, there is deformity of joints already formed when the patient comes to you. Definitely we have to, whether the history is like 10 years or 3 years or 4 years. But once we could find the deformed joints, especially the phalanges, okay, the distal phalanges and the toes, the distal toes, it will be like this, okay, with this deformity has already found in the patient. We need to definitely understand it will be difficult for us to cure the disease back to normal, but we can provide yapyatva to the disease. We can make the patient live his life comfortably without progress of the disease. So any kind of what you call it as joint disorder spectrum, rheumatoid arthritis, either psoriatic arthritis, or SLE when it presents with the joint manifestation more. Of course, SLE has got a spectrum where all organs, especially the kidneys and all, are affected more, and you could find albuminuria, etc., in the clinical care spectrum. That of course has to be dealt in a different way, but even SLE with joint presentations more can be understood or divided in the spectrum. So the possibility of SLE and all, I believe, is we could find the clinical presentation, this joint manifestation will not be there much. We could see especially it in the background of Uttana Vadrakta, Pitta, Adhika Pitta, Rakta Vadrakta in the background. And all those things will be able to manage according to Avastha, seeing the principles of Jwara. So clinically, these two aspects I think we need to understand. So Vadrakta, as I mentioned, clinically, we need to understand the doshic variability. So guidelines given by Acharya, what is that? Vadika Vadrakta, Dhamanya Anguli Sandhinam Sankochaha, Angagraha Atiruk, Kunchana Stambana, Shita Pradveshascha Anile Adike. So this is usually seen towards the end or later stage of the case. But when a case comes, she says, when I feel the classical presentation is when I have this Sheetatvam, what you call it as the wind from the fan, I feel very much cold, doctor. I feel like just getting into, this is the usual thing that they present. If that is the situation, definitely it is Vatottara Vadarakta. Along with that, Shotasya Karshnyam, Raukshyam, Shyavata, Vridhihanayaha. So this Shofam will be somewhere, sometimes they say, in the evening I have Shofam, doctor, sometime in the morning I have this swelling, then it goes subsides. And you could see Karshnyam, that discoloration, darkness in the especially joints of the lower limb, this ankle and all, you could see that. If that is the spectrum, it is Vadottara Vadartha. So in that area, if that is the condition when the patient comes to you, if that is the situation, we need not think of the so-called Vamana or Virechana in the background. If the patient is having enough Bala, we can directly go for some external Sneha Spedas followed by Kshirasti. So Kshiravasti, the guidelines given by Acharya, where Niruha can be done. Treen Malaihi Haret. So there he says, when the individual is having Prakshina dhatus, he cannot undergo Vamana or Virechana. In that situation, he can undergo Niruha with the Kshira, the sutra that we have seen yesterday. Okay, so that is the situation. Definitely, this could be the possibility. Okay. One second, just give me a 1 second break.
Yeah, ma'am.
Okay. So we'll restart. So as I mentioned, should we go for which karma in this avastha? As I mentioned, it is the clinical presentation of Niruhavasti or Niruha situation wherein Acharya very specifically gives us a guideline. What does that gives us the guideline? How when to do basically Niruha? He guides us basically Vamana and Virechana. Pittam va kapapittam va pittasya gadam haret is Sramsanam. Treen malan bahihi haret pakwa shestidan is actually, I am not repeating the shlokas from yesterday's class, but Jwara kshinasya na hitam vamanam na virechanam kamam tu payasa tasya niruherva haren malan. He says about that. Niruho balam agnincha vijwaratvam mudam ruchim paripakveshu dosheshu prayaktah dirgamavahe charaka. So what is the background? Kamam tu payasa tasya niruhairva haren malan. So when the prakshina, so in Vadottara, a clinical condition, when the patient comes with sankocha, shita pradvesha, and in that case directly we can go for kshiravasti, need not go for vamana or virechana. Now moving on to the next clinical presentation of Rakta Adhika Vadrakta. This, I have seen even in the background of SLE. Okay. Shvayatuhu Brasharuk Todaha Tamraha Chimichimayate Stigdha Rukshaihi Shamam Naeti Kandu Kledanvito Asriji. SLE patients will be having mostly kandu here, there and all, swelling here, there and all. We go for some Ruksha Kriya pain will not reduce. We go for Snigdha Kriya pain will not reduce. In that case, the possibility best is definitely Rakta Moksha. Okay, Rakta Moksha either in the form of Siraveda generalized, because of that severe pain that will come down. So whenever the patient is having Raktaja background, definitely Rakta Moksha has to be taken. Has to be the part. Okay. Now, when we are thinking of Paitika background Rakta, Vadrakta, these are again, when a Vadrakta patient comes to you, they say, I have pain, doctor, in such a way that you touch me, I'm unable to, bear that touch itself. Okay. And Ragaha, Pakaha, Vedaha. Veda is the kind of prickling pain. Trishna, Madha, Brahmaha. Often he will be having some kind of Brahma, giddiness and all. So in that perspective, Paitika Vadrakta happens. So sparsha sahishnutvam is one guna that we generally think of. So patient will be having all joint pains, etc., but we will be unable to touch the body itself because it will be so hot as such. In that case, we will be categorizing the case as Paitika Vadrakta. And Staimityam Gauravam Snehaha Suktihi Mandacha Rukka Kabhe. So Manda Rukka. But the patient will be having Gaurava. Patient will be having Sukti. So Taimityam is he'll be having very much stiffness, unable to move. That's Timitata, similar to like more Tamoguna Pradurbhava. So all these things are addition to the general lakshanas told in the Ruk, Kandu, Shwayatu, etc. in the background. Ruk, Todayama, Uttana Vadrakta, Gambira Vadrakta. The general symptoms that Acharya has already told about Utthana and Gambira. Gambire, Shwayatuhu, Stabdaha, Katino, Antar, Bhrisham, Artiman, Shavatamra, Atava, Dahatoda, Surana Pagavan, Ruk, Vidahan, Vito. So this is additional or supportive things that which dosha dominance is there. So as I mentioned, if it is Vatika, we can go for Kshiravasti as mentioned by Acharya Charaka. Guidelines for Jvara. Raktaja, don't go for anything. Ushna Ruksha Shamam Nati, Raktamoksham is the possibility. Paitiga, definitely we can make him undergo Virechana. So what about Virechana? He says, Pittamba, Kapapitamba, Pittashyam, Gatam Haret, Virechana. So we need to understand whether the dravya, the doshas has reached Pittashyam Gatam. And Kabaja, definitely Vamana is a possibility. Okay, so Vamana is a possibility wherein Acharya speaks about the lakshanas, Utklishte, Samutklishte, Kafapraye, Chale Male. That is not the situation. Definitely you need not go for Satya Vamana, but Kabha, Tani Upastita Doshanam, Kabha in the background, Nama Shestite, definitely Kabaja, Vamana is a possibility. Now, for Vamana or Virechana, Snehapanam is a possibility. And where to do Snehapana? As I mentioned yesterday again, what was that? Vada Vittottare Kabhe Mande. So, Vada Vittottara background, Manda Kabha background has to be there when we need to introduce Snehana. But again, at the same time, if we want to go for either Shodhana Snehapana also, this Vada Vittottara and Manda Kabhavastha has to be there, because if Kabhavastha is high, we need not go for any kind of Snehapana itself. We can make him directly undergo a Vamana. So we have to select Snehapanam. Snehapanam, once we fix which is the drug, is our next question. So I would like to share with you a case of, actually the case was recently 8 months diagnosed case of rheumatoid, not rheumatoid arthritis, it was actually gouty arthritis. Okay. So the patient was on furosemide as such. Okay. And he was having furosemide and some other NSAID like kind of thing. Furosemide and one more drug, something like Ipride or something he was having. So he was actually a farmer from Andhra Pradesh. So when he had come to me, he was having all joints broken like anything, and actually joint pain, swelling and all. He had come, little swelling and all he had come. So I could see he was like, on this Vakratvam had to an extent not formed, but there was swelling. He was like a little bit dark. He told he had become lean. I could see Karshnatvam in him. I could see pain. If I touch only, pain will be there. That Raukshada and Shyavata of Shofa I could see. And he was on these drugs and told me now controlled. So I told, it is like I felt it is Vatottara Vadrakta. So since it is Vatottara Vadrakta, I planned for a Snehapanam and Virechana, of course. And I was planning for a Snehapana Virechana followed by Vasti. This was my plan. Before Vasti, I definitely need to make him undergo a Shodhana, because the patient was not as Abala or not only Vadottara in all perspectives. So, but Vata dominance was there. So I initially started with some Dravasvedam and Dhanyamala Dhara. As always Vadrakta has got Pitta Rakta in the background. Generally all Svedas are contraindicated, and even if we want to go for any kind of Sveda, Dravasvedam is the possibility. That is why we go for Dashamulam Kashaya Dhara or Dashamulam and all Vatahara Patra is added and then made into Kashaya, and then Dhara is done, or Dhanyamla Dhara. So in that 2 or 3, 4 days we had done that, and he was fine with his pain and all had come down. So I started Snehapana to him. So he was telling his uric acid was almost 12 before 4 months or something. So he's on drugs like that. I started Snehapanam. So I planned actually Nimnonnata Jwara Haram Balavardhanam Cha Indu Kantam Ghrutam. I actually selected and made the patient undergo Snehapanam. So second day, third day, he was much better. So, out of over enthusiasm, I withdraw. He told me, Doctor, shall I avoid all allopathic drugs? Okay. So I was also like, fine, okay, you avoid what is there, your pain and all has come down now. You avoid it, I thought. Okay, it was like greatest mistake that I did. During Snehapana, I asked him to withdraw the drug. And what happened, third day he withdrew the drug. On the fourth day, he had some swelling slightly increased. He was not knowing language. I was not there, some program. So my medical officer was there. So language issue something. And she told he's okay, but some slight swelling, some upleshna might have happened, we will see. So I thought, okay, no issues. On the fifth day, I asked him to continue Snehapana. So we had started with 30 ml. Next day, 70 ml. Third day, I think 90 ml. We withdrew furosemide. On the fourth day, 120 was given. He had increased swelling, but I did not withdraw. On the next day, I was planning Madhyama Matra Snehapana, so I had given 150, 160 ml Snehapana. And what happened was, on the fifth day evening, he had high-grade fever. High-grade fever in the sense, nearly 103, 104 degree. We tried to, so I had a call that he was having some feverishness or something. So I was planning, it's okay, now we'll manage, we will observe. So don't give Snehapana on the other day. Evening we will observe, but by evening 7:30 he started having high-grade fever with all vomiting. Food was also not a problem, but the patient was also coaxed with the procedure of Snehapanam anyway. Food was also there, but he was a very cooperative, kind, good-hearted man. Okay, he still, I am ready to do anything to avoid this kind of allopathic drugs. I just want to make my disease get rid. But what happened on the fifth day? High-grade fever. We actually tried to manage it with Vettumaran, Sudarshanam, nothing happened. And finally, we had to give paracetamol. Even with paracetamol, 3 to 4 hours only, his pain increased, high-grade fever. And, as a result, his all joints swelled up. Especially both the knees got swollen up. And he was unable to walk. He was able to walk very freely when he came here with pain and swelling. Now, before that, pain and swelling had come down. And this had aggravated like anything. Then I tried all kind of lepam. Then, it was all like emergency management for us. We tried, then I did Jaluka, and then what was the greatest thing was withdrawal of that furosemide was the big thing. And I could understand at that point because he was with all these drugs and his lakshanas were actually subsided with those drugs. And my assessment of Vadottara Vadrakta, when his lakshanas were subsided with these anti-inflammatory or anti-this drugs, was not correct as such. And otherwise he was Utklishta Avastha. Probably he was not indicated for Snehapana itself. And this withdrawal of drug had added on. And it had actually created Sneha Vyapat, leading to Jwara. So what is the treatment? Amatraya hite kale mityahara vicharataha. What he says? Takra arishta khaloddala yavashyamaka kodravam. These are the possibilities that you have to go. So Sneha Vyapat. So Takra arishta yava. So we had stopped that. We had to start some internal medication. And for the knee joint pain, I had to go for Lepana, and then I had gone for Jadokavacharanam, and then I had gone for local dharas. After all those circus, 3-4 days, it got subsided. And of course, internal medicines, the allopathic drugs was restarted. But the patient was so fed up with the whole process that he did not turn up. You just leave me. I just did a simple Rudu Virechana and like local procedure. And he went, it was horrible for me. I'm not going to continue with Ayurvedic medicines. Actually, he was referred to me by an allopathic doctor. So that was my from Andhra Pradesh. So it was a bad experience for me. But as I mentioned, to understand this avastha, when already the patient is under allopathic anti this drugs, it is very difficult, and we have to keep even that in mind. So making somebody undergo, if it is not Vada Vittotre Kabhe Mande Avastha, it will backlash. So we have to make sure whether it is Vada Vittotre or Kabhe Manda Avastha. Probably his was not Manda Kabhavastha. That is why even with the drugs withdrawal that had come up, and I had introduced Snehapana in such a way when Manda Kabhavastha was not the situation. So that I think we need to think of. Okay. So again, the spectrum of drugs that we commonly select in the RA or the Madhyama Roga Marga spectrum is Tiktaka Ghritam with Paitika is presentation, Gugulu Tiktaka Ghritam and Vadaka Bhaja background, Indu Gandham when the bala of the patient, immunity of the patient is Sukumaram, etc. Sukumara Ghritam, especially in females, you could see the indications of Sukumaram has got so many that spectrum things. And in that category where Grita cannot be given, okay, like Medho Maruta Rogishu, Thailam, Lagava Dardyarthi, Krura Koshteshu Dehishu, Granthi Nadi, Krimi, Shleshma Medho Maruta. So in Shleshma, Medho dominant Vadrakta, we usually prefer Thailam, and that Thailam is Madhi Ashtyadi Thailam mentioned in same Charakas, Vadrakta Adhyaya. So in that way, we select Snehapanam, but this principle has to be always kept in mind. As I mentioned, Vada Vittotre and Kabhe Mande, the Kalam, I had an experience of doing Snehapana to a Vadrakta patient, Gugulutikta Gridam Snehapanam, during summer to a female patient. Within 3 to 4 days, she had developed a urinary tract infection. Because it was Ushna Kala and the patient female being Ushna, Gugulu Tiktaka was again an Ushna Dravya. So it has been very specifically Nisheva Pitte Pavane, Pittavatyapi Cha Nishi. So when it is Paitiga dominant Samprapti, Acharya gives us an option that Nishi, Ratri has to be the time period for use of Krita. It is not that morning can be done. Of course, when we are doing Shodhananga Snehapana, morning has to be the time. But that Kalam, Ushna Kalam, we are selecting Gugulu Tiktaka Grita in a female patient was the wrong selection. I could have gone for either Tiktaka Grita or something. That would not have resulted even in such a situation. So, considering all those factors, we need to select the drug for Snehapana. Now, when this Snehapana could be either for Shodhananga Snehapana or for Shamana Snehapana. As I mentioned, the general line of what you call it as general line told for in Jwara Chikitsa by Acharya Charaka, or in even Ashtanga Hridaya says the same thing, no? When he says Langhanam, Svedanam, Kalo, Yavagustikthago Rasaha, Pachananya Vipakwana. So Langhanam, Svedanam, Kalo. So if the patient is indicated for Langhanam, Shodhananga, if they're having Bala, then Shodhana can be applied. If it is Madhyama Bala, it is Deepana Pachana, and then Deepana Pachana can happen through Kashayas. So internal medicines we can give Amrutotram, Shatdharana, Manjishtadi, etc. in the initial stage according to the dosha. And then next stage only we have, and after Bahiparimarjana Chikitsa, even we are planning or advising the patient to be done at the home itself. We have to think that first Langhana, Svedana, Kala, Yavagustiktaha, Pachanani. So that Langana through Deepana Pachana, then Svedana, some external procedures can be used. So, and only after that, towards the end, as a, what you call it as a maintenance therapy, we go for Shamana Snehapana. In that Shamana Snehapana also, the common drugs that we select is the spectrum that I had mentioned earlier. So in Bahiparimarjana Chikitsa, I can go for what you call it as Sankara Svedam. That means a Potala Svedam. I can go for a Drava Svedam. I can go for any kind of specific Pinda Svedam. So how can we select that? Of course, that is another area. One thing we have to think, when there is Pitta Dushti, Rakta Dushti in the Samprapti, the selection of Sveda should be Drava. So as given guidelines given by Sa Uddharta Venasa Shwase Triga Prishta Katigrahe Svedanam can be done. Jwara guideline. So if he is having Uddharta Venasa Shwasa or pain in Kati Prishtagraha, any of the sandhis, then Svedana can be a possibility. But think if Pitta, it is Drava Svedam. Only you cannot, when the patient has got swelling and you're unable to even touch the patient's body, then you ask, we make the patient undergo a portalus svedam, a kiri, okay, or the so-called any kind of bolus preparation should not be done. It has to be done only in Vata Kaphaja dominant situation where there is stiffness in the background, difficulty in what you call it as making the movements, etc. But if there is swelling more with the Sparsha Sahishtatvam Paitika background, as I mentioned earlier, some Drava Sveda with only Guduchi, with the Dashamulam, with the Dhanyamlam, with Dashamulam and Vatahara Patram. These are the possibilities that we need to think. So Bahi Parimarjana. And if the patient is not at all indicated with for Svedana, contraindication of the situation, and you have the shofam in the background in that avastha, then only lepanam you have to undergo. That lepanam can be Jadamayadi Churnam. Okay. Or if it is Kabha dominant, Nagaradi Churnam. This is the way that we move on. Okay. So if your place, whatever the lepas you use practically, if it is Kapha, only Shunti is used. If it is Pitta in the background, Rakta Chandanam and Chandanam can be used. So in that perspective, lepas can be used. Okay, so that Bahi Parimarjana Chikitsa, any kind of Sveda, the guideline given by Sa Uddharta Venasa Shwasa Triga Prishta Katigrahe, in that spectrum of Lakshanas has to be taken care of when Acharya speaks about the possibility of Sveda. Okay, so he says Vata Shleshmatmake Sveda Prashastaha. So in Vata Shleshmatmaka Avastha, Sveda is Prashasyate. Otherwise, if it is Pitta, Drava Svedam only has to be considered. Okay. Now, as I mentioned, Snehapana has to be considered again according to Avastha. So, Shodhananga Snehapana, as I mentioned, if the patient is indicated for Shodhana according to the Avastha that we have decided, Shamana, if we think Shodhana is not needed, but what you call it as we can go for Shamana of the patient, then what is the important thing? As told, when the Prakamshitaha, when there is Shuddvato Ananno, when the patient is having hunger, without having any internal food or something, during the time of hunger, medicines should be introduced for Shamana Snehapana. For Shodhananga Snehapana, Hyastane Jirna Eva Anne. When the food is digested from the previous meal, that is because for Shodhanangam, Utkleshna has to be induced in the body. For Shamana, the Grita has to go for and make the dosha Shamanatvam. And then Brahmano Rasamadhyadehi Sabhakto Alpaha, he said. If the patient is having, after all these processes, his Prakshina Dhatu, he's having Bala, Vritya, Sukumara, Prakshina Dhatu and all, then he has to undergo Brahmana. So Brahmana will be Sabhaktehi or Samadhyehi, or you can add Krita in Arishta and give. You can add Grita in milk and give. So according to Avastha, we can again decide which is the Snehapana to be given. Okay. Now, as I mentioned, the Sveda spectrum, it has to be Drava Svedam if it is in the background of Paitika, Vadrakta, whether it is Kashaya Dhara or Dhanyamla Dhara. When Vada Kabhaja spectrum it is there, Sankara Svedam or different Pinda Svedam. Sankara, we say it is whenever some Pindas is dipped in Amla Dravyas and then done, that is called as Sankara Svedam. In a very practical sense, we do that. So usually again it is Dhanyamlam or we say Arikadi, that rice brush water, or Kulatha Kashayam or Dashmulam Kashayam. These are the common things that we take to dip the potally and then go for Sveda. So that the Dravya and the Sveda becomes a medium. So the medium that we are applying the body acts to support or what you call it as to revert back the pathogenesis. The guna that we are applying of the Dravya also act over there. So when the general guideline of Sa Uddharta Venasa Shwasa Triga Prishta Katigrahe Vata Shleshmatmake Sweda Prashasta, the general kind of Jwara, has to be taken care in that perspective also. Now, as I mentioned, Virechanam, definitely where Acharya speaks about Virechanam, the space, what do you call it, as the clinical situation, he has given us direct guideline where we can go for Virechanam, what do you call it as, where if Virechana, if it is Anupastita dosha, and if we go for Vamana in any Anupastita dosha, the patient can have Hrudroga, Shwasa, Anaha, all these things. Yesterday we have seen. So in Virechana, again Acharya says Pittam va, Kapha Pittam va, Pittashayagatam Haret, Samsanam. So Pittam va, Kapha Pittam va. As I mentioned, if you are having Paitika Lakshanas or Kapha Pitta Lakshana or Pitta Vata Lakshana, Virechanam can be the choice. So that avastha, Pittashayagatam only has to be taken care of. And you know, even in clinically, usually when Vadarakta patients come, we don't make them generally undergo Vamana. We always think it is Virechana the best option because Vadarakta, no? But some cases I have an experience wherein you go make them undergo Virechana, but you know, proper this, what do you call it as, recurrence of the clinical situation happens within 6 months, 8 months, or not fully, but joint pains comes up. And then I could see in that avastha, because when they undergo nidanas, climate changes, everything comes up. Then at that situation, what I observe is actually the patient had kapha dominance in the samprapti, and I could have made her undergo kapha vamana and then followed by virechana. So in classics also they give us, you know, if it is like making, if somebody is making somebody undergo virechana without the vamana, grahani machadayati, there is grahani which gets a coating and that is not removed properly. And somewhere, you know, this kapha will be there always in the body. So it's always good to make somebody, we have, so undergo vamana followed by virechana. But I think that avastha analysis is most important. If we could find the so-called pittashayagatam lakshanas, and Pitta Vatam in the background or Pitta Kapha in the background, Virechana is the possibility. Otherwise, Vamana can be a possibility provided the patient is Balavan, etc. Now, as I mentioned, is Vamana a possibility in Vadarakta? Generally, you know, in Vadarakta, when a Kushta case comes, we generally think of Vamana. When a Vadarakta case, we generally think of Virechana and Vasti. Very rarely Vamana. But as I mentioned, there are clinical situations of kapha dominance, as like Taimitya, Stamba, Gaurava, etc. that we have seen. If that was a clinical presentation of the patient right from the beginning, definitely Vamana was a possibility. So the avastha that Acharya Charaka gives us, Amashaya Sthitam, any dosha that is Amashaya Sthita, he specifically mentions it. Asahrillasa praseka annadvesha kasa vishujika saddo bhuktasya. That is acute situations wherein we have to go for vamana. But otherwise, basically, kapha pradhanan, klishtan, doshan, amashya sthidan, buddhva jwarakaran kale, vamyanam vamane arhe. So vamana arhas can may be made to undergo. So this principle, kapha pradhanan, klishtan, amashya, dosham, amashya sthidan. So Utklishta avastha with kapha dominance, dosha in amashaya. So even Utklishta avastha is not there, but dosha dominance is there in amashaya once we understand how the lakshanas of Gaurava, Atmana, etc. In that case, Vamana has to be a possibility. Okay. Now this is actually an output of a Vamana case, which I had done, as I mentioned, because of this joint pain and all. I had made her yesterday, as I think I had discussed the case, wherein I had made her undergo all Sneha Ruksha Sveda and all, but she was unable to, having that pain reduction was not, and I had made her undergo Satyo Vamanam during, you know, it was an Amavata spectrum, okay, it was RA, it was seronegative arthritis, RA was negative anyway, but this general body pain swelling was there. Had made her undergo Vamanam with Yashti Phantom at 11 o'clock, 11:30 in the morning. And you could see the output basically. She was not at all prepared with any, what you call it as preparation for Vamana or something, no. See, the whole spectrum has there. Okay. She, you could see the kapha coming out. You could see even at that particular time. And after this particular thing, she had been relieved of her clinical situations to a great extent. Then we continued that Rukshana therapy. She was better. Okay. Now coming to Vasti spectrum, as I mentioned, Acharya gives us a guideline where to go for Vasti very specifically. Jwarakshina hitam navamanam kamam tu payasadasya niruhaihi harain mala. He specifically speaks us. And he actually, that Anuvasna Vasti's indication, Jware Purane, Sankirne, Kafapitte, Dridagne. So, if Purana Jwara, that means if a case is Purana, but he is having Dridagni and having Vruksha Baddha Purisha, definitely Anuvasana is a possibility. So in practice, Vasti, we commonly follow Madhu Tailika Vasti. In Madhu Tailika Vasti, Madhu Taila Samay Karshaha, Saindava Dvitijurmisihi. So that is the Erenda Mulak Padena, Rasayano, Prameha Arsha, Krimi Antra Vrdinu. So there, rasa, is the property that we commonly manipulate. And what is that is, Erenda Mula Klada in the background of Adraktam is replaced by Guduchi Kashaya. Only Guduchi is taken. And then Guduchi Kalgam is taken, Saindava is added, and for Taila we add Madhyashtari Taila. So Madhu Tailika Vasti is modified. So the general principle of where to add Vasti is taken care of. Along with this, the drug is modified. In Kshiravasti, as I mentioned, once Madhu Tailika Vasti is given, then towards the end we go for Kshiravasti after Shodhana. Okay. But as I mentioned in the earlier part, if the dosha is Vada dominance and the patient is indicated for Niru, Kshina and all, Kshiravasti can be directly given to the patient, wherein the common thing that we use for Kshira is again Guduchi and Kokilaksham. Kokilaksham is singly it is taken, and Guduchi is singly taken. Okay. So Guduchi and Kokilaksham is singly taken and then made into Kshira Kashayam. The practical way that we do is 15 gram of Guduchi, 15 gram of Kokilaksham, added with 250 ml of milk and 1 liter of water, reduce it to 250 ml. Madhyashtari Thailam and Tiktaka Kritam is taken. So if it is like Avara patient and all, 250 ml Thailam, 120 ml Madhu, 120 ml Kritam, and 120 ml Thailam is taken. No kalpam is added. Kshirad do prasurdoma karyo madhu taila krudad traiha khajena madido vastir vadagno balavarnakvat. So that spectrum we are using in the spectrum of Adrakta. So as I mentioned, whether it is rheumatoid arthritis, commonly Guduchi, Kokilaksha. If it is SLE spectrum, we use for only Guduchi, we usually take. Psoriatic arthritis, even there, we usually don't go for much of Vasti. But if the pain is more like the deformity, pain, clinical presentation is more in Adho Nabija Vikara, Adho Nabija presentation, Vasti is taken care. There we usually use Panchatiktaka Vasti. That means for the Kashayam, we take Panchatiktaka. Panchatikta is like the 5 drugs of Gugulutiktaga miniature. That is Nimba, Amrita, Vrisha, Patola, Nidiktigana. That is Chunda. What is that? Brihati Dwayam, Amshmati Dwayam, Annamang that. So Nimba, Amrita, Vrisha, Patola. Vrisha is Vasha, Patola, Nidiktiga. These 5 drugs are taken as Panchatiktaka, and that is added as Kashayam when we are thinking of skin diseases. If we have to go for skin, because as such Kushtam is contraindicated for Asthapanavasti. Masan Saptacha Garbhini, Kushticha, Madhumehicha, Masan Saptacha Garbhini is contraindicated for Asthapanavasti. But in Charaka Siddhisthanam, we could see Panchatiktaka Kashaya Vasti mentioned with its indication Kushta Abhishyanda Mehanutta. That means a clinical situation wherein we have to make him undergo Kashaya Vasti. You can use that combination of, it has got again, Patola, Nimba, Saptachada and all. Almost similar, it has got Sarshapa Kalka, a small combination change. What we practically do is, in Madhu Tailika or Kshiravasti, Panchatiktaka Kshiram is taken and then the Dravyas are added. When Adho Nabija clinical presentation is more. Okay. Now, as I mentioned, Rakta Moksham is another possibility. Acharya Charaka, even in Jwara, when Ruksha, Snigdha, both are not working up, Rakta has to be taken care. So many a times, when we do make them undergo Sneha Sveda or Sveda, Ruksha Sveda and all, Still they say pain is there. I have pain in the neck area, low back here, there and all. Okay. So in that spectrum, we have to think of the possibility of Rakta Moksha. So this is actually a case of, again, chronic Vatarakta. It was like a kind of stasis eczema. She was standing for a long time, and then we had a Vranam later. Okay. So actually in that case, we had tried Allah. After we had made him undergo some Dravaspedam with the Triphala, Nalpamaradi, Kshalanam and all. That wound we had made him undergo Jaloka. Okay. So that was the thing. But before that, even Jaloka, even with Rakta Moksham, before Rakta Moksham, some Poshta Shodhana is always good to make that repair activity better. So what we do is, if a patient is admitted with such kind of Ranas, we will make him undergo either a Virechana or a Kshiravasti. Only then we will make them undergo Shodhana, Rakta Mokshana. So always it is like Kapha Pitta has to be like removed before Rakta gets worked out. The patient is having very low Bala and all, of course that is evaded, but otherwise that is always tried. Now this is another, very commonly practiced thing. Nowadays it's Hijama, a modified version of Shringam. As I mentioned, in all those cases wherein Ruksha, Snikta and all cannot be, means the patient does not respond to that, still he has got pain over here, there and all, we generally go for this Hijama. Even in Vatarakta cases, especially in the chronic cases like, joints, especially elbow, knee, and then it is neck and low back region that we commonly use. Neck and low back is the most commonly used clinical parameter. Okay. Now, you could see after this Hijama that we had actually done this dry Hijama also. We initially tried dry Hijama and then go for wet Hijama in some cases wherein Rakta Dushti is not as high as as intended in the patient. So this dry Hijama, once we do that Hijama and we leave the pressure point, you could see the reddishness in the background. If there is reddishness in the background, it indicates there is proper Rakta Dushti in the background, no doubt about it. If there is no much Rakta Dushti in the background, if you just pump, you will be knowing that Hijama cup and will be that sucking the pressure. There will be no color at all. It is if there is Rakta Dushti, it will be reddish in color. Sometimes even we are doing dry Hijama, the bleeding does not, we need not induce bleeding also. The spot itself starts bleeding. So that is the situation. So this is another criteria wherein we could see, it is not a Snehana or Spedana that's going to respond, but it is these points that need to be manipulated. Okay. Now this is another thing, something called as Murtha. It is actually a Shirolepam. Why I put it over here is, when Acharya Charaka speaks about Vamana, Virechana, Vasti and all, finally he speaks about where to use Nasya. Okay. Gaurave, Shirase, Shule, Vibhandeshu, Indriyeshu and that. So in that spectrum, he speaks about Nasyam. All kind of Murtha Prayogas, either it in the form of Shirolepa, Talam, Nasyam, Shiro, Vasti, etc. All those things for us, that can be a possible guideline. Gaurava, Shirasa, Shulaha, Vibandha Indriya. So there is Vibandha Indriyas and this thing. So, patients sometimes do have this, neck pain continuously in the background, heaviness of the head in the background. In that situation, we do Shirolepa. And though, this Shirolepa, when he speaks up, how should we put up Shirolepa? How long should we put up Shirolepa is? This is actually a criteria. When we remove the Shirolepa, that inside that lepam, there must be some droplets of water, which indicates Kleda Nirharanatam due to Ushna Guna from the head passage. That is the traditional practice over here. It was actually like that. So when we put talam in a patient, the talam has to be removed when that Ushna Guna in the body has to be, because this is